You are welcome to this session. We'll be going through Polycystic Ovary Syndrome. I am Dr. Abi Antonia Atitilayo, a senior registrar in the Department of Obstetrics and Gynecology, Obafemi Awolowo University Teaching Hospital, Ile-Ife. At the end of this topic, we are expected to understand the etiopathogenesis of Polycystic Ovary Syndrome, to recognize the different presentations and make diagnosis as appropriate, to be able to assess patients and offer the appropriate management to each patient according to their symptoms. We shall be following this outline: the introduction, epidemiology, etiopathogenesis, clinical presentation, differential diagnosis, management, complications, and conclusion. Polycystic Ovary Syndrome is a common endocrine metabolic disorder in reproductive age women, traditionally described as gynecological endocrine condition due to its complexity of presentation and with long-term effects on the overall health of a woman. Polycystic Ovary Syndrome is a polygenic disorder with combination of genetic and environmental factors inherent in its pathophysiology. The knowledge base is rapidly evolving in the areas of definition, pathophysiology, treatment, and possible long-term consequences. Polycystic Ovary Syndrome is a disorder that is characterized by hyperandrogenism, ovulatory dysfunction, and polycystic ovarian morphologic features. It was first described in 1935 by an American gynecologist, Evan F. Stein, and Michael L. Leventer, and that is why the name was given to it as Stein-Leventer syndrome. Stein and Leventer describe presence of bilateral polycystic ovaries, thickened ovarian cortex, amenorrhea, hirsutism, and infertility among the women that they encountered. Adams et al. In 1985 used the ovarian morphology criteria, and he described 10 or more cysts of 2 to 8 mm in diameter arranged around an echo-dense stroma. In addition to the classical features of obesity, oligo or amenorrhea, and hyperandrogenism. In 1990, National Institute for Health Conference considered clinical or biochemical hyperandrogenism and chronic oligoanovulation as being key in the diagnosis. In May 2003, about 27 experts on polycystic ovary met in Rotterdam, and this was sponsored by the European Society of Human Reproduction and Embryology and the American Society of Reproductive Medicine, and they added the ultrasound characteristics of polycystic ovarian morphology. 3 years after, a task force assembled by Androgen Excess and Polycystic Ovary Syndrome Society conducted a systematic review and concluded that Polycystic Ovary Syndrome is a disorder of predominantly androgen excess. They therefore excluded the non-hyperandrogenic phenotypes. In 2012, National Institute of Health organized a workshop for 29 polycystic ovary syndrome experts to review the diagnostic criteria and recommended the European Society of Human Reproduction and Embryology with the American Society for Reproductive Medicine of 2003 as the criteria. However, they added that the detailed phenotypes should be described in patients. And this is the Rotterdam criteria, sponsored by the European Society of Human Reproduction and Embryology and American Society of Reproductive Medicine in 2003. And it was agreed that presence of 2 of these 3 criteria must be present to make diagnosis of polycystic ovary syndrome: oligo and or anovulation, hyperandrogenism, clinical and or biochemical hyperandrogenism. Polycystic ovaries, which is described as 12 or more follicles of 2 to 9 mm in diameter, and ovarian and or ovarian volume greater than 10 cubic centimeter on transvaginal ultrasound. And 1 single ovary may fulfill these sonographic criteria. The phenotype described by the National Institute for Health is hyperandrogenism, ovulatory dysfunction, polycystic ovarian morphology. B. Hyperandrogenism, ovulation dysfunction. C. Hyperandrogenism plus polycystic ovarian morphology. and D, ovulation dysfunction and polycystic ovarian morphology. Recently, which is the most recent definition of polycystic ovary syndrome, the Rotterdam criteria was endorsed by international evidence-based guidelines for assessment and management, and this was published by Center for Research Excellence in Polycystic Ovary Syndrome. And the criteria consist the Rotterdam criteria that we have earlier described. The epidemiology of polycystic ovary syndrome. The prevalence depends on the choice of diagnostic criteria used and the ethnic background ranging from 2.2 to 26%. The World Health Organization estimates that it affects about 160 million women worldwide as at 2010. One community-based prevalence study using the Rotterdam criteria found that about 18% of women had polycystic ovary syndrome and that 70% of them were previously undiagnosed. Fentola et al. Reported prevalence of 18.6% in Ogbomoso, a prevalence of 12.2 to 27.6% has been reported by Akpata in Benin, and is said to be the most common cause of anovulatory factors in women who are attending clinic for infertility. The epidemiology also varies by ethnicity. It has a relative mild phenotype in Caucasians with normal body mass index, severe in Caucasian women with high body mass index, especially in the North American and Australian women. It is with more severe asceticism in Middle Eastern women, Hispanic and Mediterranean women. Increased central adiposity, insulin resistance, diabetes, metabolic risk, and acanthosis nigricans in Southeast Asians and indigenous Australians. Lower body mass index and milder asceticism in East Asians, and higher body mass index and metabolic features in Africans. Etiopathogenesis of polycystic ovary has been described as being polygenic, and it is said to have a familial component with identification of a possible male phenotype in polycystic ovary syndrome, suggesting a genetic origin of this syndrome. Commonly, first-degree male relatives have premature balding and metabolic syndrome. Some family studies suggest a possible autosomal dominant phenotype. However, a large twin studies on women with polycystic ovary syndrome found a high degree of discordance, suggesting a more complex pattern of inheritance. In some rare instances, single gene mutation can give rise to the phenotype of the syndrome. Current understanding of the pathogenesis of the syndrome suggests, however, that it is a complex multigenic disorder with varying factors. There is some evidence that exposure to higher than typical levels of androgens and the anti-mullerian hormone in utero increases the risk of developing polycystic ovary syndrome in later life. It is said to have environmental influences, especially those that contribute to obesity like diet, lack of exercise, sedentary lives. The pathogenesis usually includes excess ovarian androgen production with an abnormal degree of insulin resistance. This is said to be central to its pathogenesis. Abnormal degree insulin of resistance leading to hyperinsulinemia in the circulation. Polymorphism in the insulin receptor gene, inducing a mild change in insulin receptor function, has been described. And this leads to peripheral target tissue resistance, decreased hepatic clearance, and increased pancreatic sensitivity with increased production of insulin. Hyperinsulinemia has direct effect on hyperandrogenism. By augmenting androgen production, it augments luteinizing hormone activity by stimulation of ovarian receptors and insulin growth factors. Directly enhances amplitude of serum luteinizing hormone pulses. Hyperinsulinemia increases gonadotropin-releasing hormone pulse frequency with a predominance of luteinizing hormone over follicle stimulating hormone. And this also increases androgen production in the thecal cells. This leads to further augmentation of luteinizing hormone with stimulated androgen production, and then it also Hyperinsulinemia also inhibits hepatic synthesis of steroid hormone-binding globulin. This is just a diagrammatic representation of the effect of insulin resistance on hyperinsulinemia. And then the androgen excess pathway in polycystic ovary. The risk factors are noted to be obesity, family history, diabetes mellitus type 2, polycystic ovarian morphology, and then insulin resistance. And all these together will lead to hyperinsulinemia and insulin and further increase in resistance of insulin. And then thereby this reduce the steroid hormone binding globulin, insulin-like growth factor binding protein 1. And then all these will lead to, because of the reduction in the steroid hormone binding globulin, there is increased free testosterone in the system. Then this also leads to production of ovarian androstenedione, which further will lead to production of androgens in the TECA system. And then sometimes the cytochrome P450 is also affected, and this leads to adrenal production of androgens. Androgen excess promotes follicle recruitment, and there is increased acquisition of luteinizing hormone responsiveness at early stage of follicular recruitment, and this leads to premature luteinization. There is decreased follicular maturation, follicular development arrest, and this leads to anovulation. Anti-mullerian hormone plays a role which is not fully understood, but it said that increased folliculogenesis also leads to increased anti-mullerian hormone, which may have inhibitory effect on the response of antral follicle to follicle stimulating hormone, and then leading to arrest of follicles. The clinical presentation. From history and physical examination of this patient presenting, one can easily infer or make the diagnosis of polycystic ovary syndrome. There is usually menstrual cycle disturbance with amenorrhea, oligomenorrhea due to the anovulation or oligo-anovulation or oligo-ovulation or anovulation. Obesity may be found in some of these patients by the time their weight is measured, and then any body mass index greater than 30 kg per meter square should be suggestive of polycystic ovary, especially women presenting with amenorrhea. The waist circumference of greater than 35 inches or 88 cm with abdominal obesity is also suggestive. Waist to hip circumference ratio of greater than 0.8. Hyperandrogenism, which could be expressed or be seen as acne, hirsutism, alopecia, acanthosis nigricans in these women on examination, can also point to presence of polycystic ovary syndrome in them. Then, in our own environment, most women present with infertility. The endocrine abnormalities, elevated serum androgens, elevated luteinizing hormone, elevated estradiol, elevated luteinizing hormone to follicle stimulating hormone ratio, usually greater than 2. Insulin resistance and hyperinsulinemia, elevated prolactin, usually prolactin could be mildly elevated in about 10 to 15% of cases. Elevated leptin, reduced steroid hormone binding globulin, high level of homocysteine are found in them. The metabolic abnormalities that could easily be found in them include insulin resistance, obesity, lipid abnormalities, impaired glucose tolerance, and type 2 diabetes mellitus. Polycystic ovary syndrome also have a later effect on women, and most of the women eventually develop diabetes mellitus, about 10% of them, cardiovascular disease, hyperinsulinemia, high low density lipoprotein, endometrial cancer, increased early pregnancy loss, hypertension, atherogenic lipoprotein profile, increased thrombotic vascular events, obstructive sleep apnea, and mood disorder. There are so many conditions that could also mimic polycystic ovary syndrome, and some of these include thyroid dysfunction, especially hypothyroidism, non-classic congenital adrenal hyperplasia, other causes of amenorrhea and anovulation, such as hyperprolactinemia in itself. But however, some of these are also associated with estrogen deficiency, whereas in polycystic ovary there is increased estrogen in the serum. Androgen secreting ovarian and adrenal tumors, ovarian hypertrichosis, congenital abnormal hyperplasia or Cushing syndrome, need to be considered in women with severe hyperandrogenism and virilization. The diagnosis. The diagnosis is based on the Rotterdam criteria, and this has been supported by the recent international evidence-based guidelines that has been just been released. The criteria, which include ovulatory dysfunction, which could be anovulation, which is the failure to release oocytes from a mature follicle, while oligoovulation is less than 8 ovulatory cycles per year. Polycystic ovary syndrome is responsible in more than 80% of cases of anovulation or oligoovulation. Clinical manifestation is seen as irregular menstrual cycle. Affected women usually present with infertility, characterized by functioning hypothalamic pituitary system with endogenous estrogen production. Irregular cycles and ovulation dysfunction. Irregular menstrual cycles are defined as normal in the first year post-menarche as part of the pubertal transition, greater than 1 to less than 3 years post-menarche if menstrual cycle is less than 21 days or greater than 45 days. This is considered as irregular menstrual cycle in them. For women who are more than 3 years post-menarche, so around perimenopause, less than 21 days or greater than 35 days or less than 8 cycles per year is considered as irregular menses in them. Primary amenorrhea by age 15 or greater than 3 years post-telarche is also considered as irregular menses or amenorrhea. The second criteria 2A, clinical hyperandrogenism. This requires comprehensive history and physical examination for symptoms and signs of clinical hyperandrogenism. In adults, it could present with acne, alopecia, and hirsutism. For adolescents, there is severe acne or hirsutism. The modified Ferryman-Gallwey score is used to define hirsutism, and a level of greater than 4 to 6 indicates hirsutism. Usually, there is self-treatment in some of these women, and so this can limit the clinical assessment in them. The Ludwig visual score is preferred for assessment of alopecia. However, currently, there is no universally accepted visual assessment for evaluating acne. Hirsutism is characterized by unwanted terminal hair growth in a male pattern of distribution. Manifests as increased midline hair on the upper lip, chin, chest, upper and lower back, upper and lower abdomen, upper arm, thigh, or buttocks. A cosmetic problem with potential negative psychosocial impacts of clinical hyperandrogenism. Stimulation of hair growth depends on circulating androgen and variability in head organ sensitivity to androgen circulation. Androgen excess underlies most cases, but there is no correlation in quantity of hair growth and androgen level. The second criteria, the biochemical hyperandrogenism, this can be assessed using the following: the calculated free testosterone, free androgen index, calculated bioavailable testosterone, androstenedione and dihydroepiandrosterone sulfates could be considered if total of free testosterone are not elevated. Assessment of biochemical hyperandrogenism in women on hormonal contraception. This could be difficult because reliable using this marker is not possible. Reliable assessment using the markers outlined above are not is not possible because the hormonal contraceptives they are on have effect on the steroid hormone binding globulin. It increases, so there may be reduced testosterone in the system. Alter gonadotrophin dependent androgen production is also found in this patient. So for these women to be assessed, there should be drug withdrawal for at least 3 months or longer before the measurement of the hormones are done. The third criteria, which is the ultrasound and polycystic ovarian morphology. Transvaginal scan is preferred, especially if sexually active and is acceptable to the patient. Avoid use of ultrasound to diagnose polycystic ovary syndrome. In clients with gynecological age of less than 8 years, ultrasound may not be reliable because there is high incidence of multifollicular ovaries in them. And for a patient who is presenting with irregular menstrual cycles and hyperandrogenism, ultrasound may not be necessary. According to the Rotterdam criteria, Polycystic ovary morphology is defined if at least one of the following criteria is fulfilled. If there are 12 or more follicles of diameter of 2 to 9 millimeter, either on one ovary or on two ovaries. And then it should be ruled out that there is no corpus luteum at this point, or there is no dominant follicle present. Increased ovarian volume greater than 10 cubic centimeter. The sensitivity of this is about 75% with specificity of 99%. Polycystic ovary appearance in ultrasound is common in about 23% of women of reproductive age. However, the incidence of polycystic ovary in this patient is about 5 to 10%. This is just showing the polycystic ovary. You can see the arrangement. There are multiple follicles with a diameter of between 2 to 5 millimeter. And then we can see the stroma is thickened. There is hyperechoic area of the stroma on the two. This patient has bilateral polycystic ovarian morphology. This is the laparoscopic appearance of polycystic ovarian morphology. Investigation that should be done is outlined below. Ultrasound, as we have discussed, and for the ovarian morphology. Increased testosterone greater than 150 nanogram per dl. Calculated free testosterone is actually more accurate where there are facilities for this. There could be decreased steroid hormone binding globulin, luteinizing hormone and follicle stimulating hormone ratio of greater or equal to 2, increased or normal dihydroepialdosterone greater than 800 microgram per dl. Serum beta HCG should be done in this patient to rule out pregnancy because some of them present with amenorrhea. Serum fasting prolactin, there could be increased prolactin about 10 to 15%. The fasting lipid profile should also be done as baseline in this patient. Serum 70-hydroxyprogesterone level less than 200 nanogram per dl normally. But if this is greater, then non-classic congenital adrenal hyperplasia should be ruled out in this patient. 24-hour urinary sample for free cortisol and creatinine to rule out Cushing's syndrome. Level of free urinary cortisol of greater than 4-fold of normal is diagnostic of Cushing's syndrome. Oral glucose tolerance test with a 75-gram glucose load should be done for this patient because of the risk of diabetes mellitus and impaired glucose tolerance in them. Treatment. For women coming with polycystic ovary syndrome, they have different presentation and different needs. And so the treatment should be channeled towards this. But mainly the objective of treatment include improving and restoring reproductive functions, prevent endometrial hyperplasia or carcinoma, reduce serum androgen to improve acne and asceticism in these patients, promote weight loss, prevent other sequelae of insulin resistance of later life. Counseling, information and education is very important in these patients to understand the condition and then to understand the possible complication that could come from this, that could follow this condition even in later life. And then this counseling and information is needed for them to comply with the management that may be instituted for them. Weight loss and lifestyle is central in the management of polycystic ovary syndrome because this could alleviate symptoms in most of the patients. And this can be done through diet or surgery. Medical treatment based on symptoms like hormonal therapy, ovulation induction agents, and then insulin sensitizing agents may be used in this patient. And in some, surgery may be done, especially laparoscopic ovarian surgery. Lifestyle and weight loss. There's strong association between obesity, hyperandrogenism, impaired glucose tolerance, and ovulation, menstrual abnormalities, and infertility, emphasizes the importance of addressing lifestyle issues in women with polycystic ovary syndrome. At least 50% of women with polycystic ovary syndrome are obese. And so this requires careful education, counseling, and encouragement, and also follow-up, and sometimes to even link them with support group. The focus is on weight optimization through exercise and nutrition. Evidence shows that 5 to 10% reduction in weight can result in significant improvement in metabolic and reproductive function, and this is also considered as a successful weight reduction in 6 months. The loss of abdominal fat may be the best predictor of weight loss. Exercise shows striking improvement in ovulatory function, sensitivity to insulin, and features of hyperandrogenism. Regular weight monitoring is recommended. Patients should be co-managed with dietitians for appropriate calorie management. In some that are not responsive to nutrition, anti-obesity agents such as orlistat can be added to this lifestyle modification. And at the extreme end of the spectrum, for patients who are resistant to all this, bariatric surgery may be considered, especially with those with a BMI greater than 35 kg per meter square. These are just diets that are considered as polycystic ovary disease diet. Healthy balanced diet, regular diet, hypocaloric, reduced fat, reduced free sugars, high in complex carbohydrates, and then let us not forget that we should always involve a dietitian. Exercise is very important. A mean 30 minutes of sweat-producing aerobic exercise daily is encouraged, and group therapy is said to give more outcomes in these patients. What are the effects of weight loss? It improves ovulatory function, spontaneous menstruation, increases conception rates with fertility restoration, reduction in androgens, increased steroid hormone binding globulin with reduction in unbound testosterone, reduces androgen stimulation of the hair and skin, thereby improving acne and hirsutism. It reduces insulin and free androgen levels, improves diabetes and cardiovascular risk, and also improves self-esteem of this patient. Menstrual irregularities. Combined oral contraceptive has been found to be very useful in this group of patients, and it enhances the regular shedding of the endometrium. Low dose is recommended because of the adverse effect that can be associated with combined oral contraceptives. Progestogens can be used, medroxy progesterone acetate, for 12 days every 1 to 3 months is recommended for those who are not combined oral contraceptives. Also, continuous provision of progesterone, such as levonorgestrel intrauterine system, can be employed in these patients. Hyperandrogenism and hirsutism. The treatment of hirsutism can be physical treatment, which include shaving, threading, waxing, and bleaching. And this can be done while waiting for medical treatment to take effect. And 6 to 9 months of regular treatment is typical because of the time it takes for hair growth to take place. Electrolysis is time-consuming and expensive, and this requires an expert. Laser and photothermolysis are more expensive, but have a longer duration of effect. Medical treatment. This prevents further progression of hirsutism and decreases the rate of hair growth. Topical agents like eflornithine can be used in these patients. Combined oral contraceptives is also useful, especially Dianet, which contains ethylene estradiol and cyproterone acetate, has been recommended. Or ethylene estradiol plus drospirenol, that is Yasmin. This also can be used in this group of patients. Antiandrogenic agents can also be employed, like spironolactone, ketoconazole, finasteride, and flutamide. And this is indicated in the treatment of hirsutism and androgen-related alopecia, especially where combined oral contraceptives are contraindicated or poorly tolerated. It should be combined with effective contraception, decrease ovarian testosterone production, and it should be combined with combined oral contraceptive if no desired result after 6 months of combined oral contraceptive treatment or cosmetic therapy. Medical treatment of polycystic ovary or hirsutism. Usually, this has been shown to suppress luteinizing hormone-dependent ovarian androgen production, and this table just shows the different medications that can be used and their doses. The role of combined oral contraceptive pills is the first line in management of menstrual irregularity and clinical hyperandrogenism. It suppresses gonadotropin secretion and ovarian androgen production. Estrogen component increases hepatic production of steroid hormone binding globulin. It reduces terminal hair growth and ameliorates acne. Induces regular withdrawal bleeding and contributes to prevention of endometrial hyperplasia. The lowest effective estrogen dose, such as 20 to 30 microgram ethylene estradiol, as found in diet, should be done. And then natural estrogen preparations are recommended to balance the efficacy and then the metabolic risk profile, side effects, cost, and availability. Treatment of infertility. For a patient presenting with infertility, patient should be holistically assessed, and other cause of infertility should be ruled out in this patient. Optimization of blood glucose, blood pressure, mental and sexual health to improve reproductive outcome is necessary in this patient. Ensure there are no other factors responsible for infertility. Aim at body mass index less than 30 kg per meter square, or for 5 to 10% reduction in body weight. Also consider the age of patients. Ovulation induction with antiestrogens, aromatase inhibitors, gonadotropin therapy, and laparoscopic ovarian surgery could be needed in some of these patients. Ovulation induction. Clomiphene citrate is a traditionally acceptable medication and the primary agent in ovulation induction with long safety record for many decades. It is a selective estrogen receptor modulator. It binds to estrogen receptor in the hypothalamus. And then this leads to compensatory increase in gonadotropin-releasing hormone pulse secretion. It could be used alone or combined with metformin in women who are clomiphene resistant. It also has antiestrogenic side effects like the thickening of the mucus, and so the timing of use is dependent on this. The dose is 50 to 150 mg daily for 5 days, starting from the menstrual day 2 to 6. Doses of more than 150 mg do not seem to confer any significant increase, either in ovulation or in pregnancy rate. Ovulation is achieved in over 80% of cases, and pregnancy in about 35 to 40% of women with polycystic ovary syndrome. There is 5 to 10% risk of multiple pregnancy in women on clomiphene citrate. Clomiphene citrate failure is said to occur if there is 6 ovulation cycle without pregnancy. Clomiphene citrate resistance refers to failure of ovulation with maximum dose of clomiphene citrate. Letrozole. This is an aromatase inhibitor and is being considered now as the first-line ovulation induction agent, especially with the new evidence that is available. It has the dual inhibition of conversion of androstenedione to estrone and testosterone to estradiol. It initiates feedback to hypothalamus-pituitary axis with resultant gonadotropin release and production. It has less multifollicular development with higher live birth rate than clomiphene. Ovulation induction appears to be more successful with higher live birth rate. Insulin sensitizing agents. Metformin has been recommended and is an oral biguanide and insulin sensitizer. It reduces hyperinsulinemia and lowers serum testosterone. Reduces insulin resistance and secretion, followed by reduction in ovarian androgen production. It has direct action on ovarian Teca cell and also reduces ovarian androgen production. This could be recommended in adults with body mass index greater than 25 kg per meter square for treatment of weight and metabolic outcome. It can also be combined with ovulation induction agents in patients who are not responding. It is recommended in the treatment of weight, hormonal and metabolic outcomes, reduce insulin resistance and thereby reduce risk of developing diabetes and other metabolic sequelae. Its benefit is of short term in reproductive function. It has direct action on ovarian Teca cell to decrease androgen production and may offer greater benefit in high metabolic risk group. There are treatments that are considered as second-line ovulation induction, especially for patients who have failed on the first-line medications. In this patient with second-line ovulation, gonadotropins are recommended. Low dose with careful serial ultrasound monitoring of follicular growth is encouraged. Options include daily injection of either recombinant follicle stimulating hormone or human menopausal gonadotropins. Treatment should be suspended if more than 2 mature follicles develop because of the risk of multiple pregnancy and ovarian hyperstimulation syndrome. This is a table to show the medical treatment option for polycystic ovary syndrome, menses, and anovulatory infertility. Laparoscopic ovarian drilling is also considered as a second-line treatment, especially in patients who have failed in the previously outlined treatment. The principle is to reduce ovarian androgen producing tissue through reducing thickness of ovarian stroma while preserving the cortex. Laparoscopic ovarian drilling has been shown to have similar efficacy to gonadotropins in treatment of clomiphene-resistant polycystic ovary syndrome. Furthermore, it is free of the risk of ovarian hyperstimulation and multiple pregnancy. The favored method is to use monopolar diatemy. Laparoscopic ovarian drilling is particularly appropriate in women who need laparoscopic assessment of their pelvis. So this could be done at the same setting. And then it's also encouraging women who are unable to attend the frequent monitoring required for gonadotropin therapy. This is just a diagrammatic a pictorial representation of laparoscopic ovarian drilling. It is a surgical procedure, and the risk of post-operative adhesion has been entertained. And then there's a theoretical risk of damaging of ovarian reserve. It deserves careful consideration, and discussion with patients is very important. It is also important to know that the response to laparoscopic ovarian drilling is not permanent, and this is not useful to treat other sequelae of polycystic ovary syndrome like hirsutism and obesity. In vitro fertilization. This is a third-line management and last resort, especially when there are other contributory factors to infertility. Development of more follicles with higher serum estradiol but lower fertilization is seen in patients with polycystic ovary compared to the general population, and also there is associated higher risk of ovarian hyperstimulation syndrome in them. In vitro maturation has been suggested as an alternative to conventional in vitro fertilization method. This is an algorithm to show the management of patients with infertility. For patients who polycystic ovary syndrome has been made and ovulation is detected, you await natural conception. However, if there is no ovulation, full fertility investigation is recommended, and if overweight, lifestyle modification is also recommended. And then if ovulation is detected after this, then patient is allowed to have a natural conception. If no pregnancy after 6 to 9 cycles, then in vitro fertilization is recommended. This is an algorithm showing the management of infertility in patients with polycystic ovary. Once the diagnosis has been made and ovulation is detected, one awaits natural conception. If there is no ovulation, then full fertility investigation is done, and then if overweight, lifestyle modification is done. If after this there is ovulation, you can wait for natural conception. However, if there is no conception in after 6 to 9 cycles with ovulation, then in vitro fertilization should be recommended. For patients who do not have ovulation induction could be done in them using letrozole or clomiphene, as earlier mentioned. If after this there is ovulation, then for 6 to 9 cycles and there is still no conception, then in vitro fertilization is recommended in them. For the patients who have failed on the first line treatment of ovulation and there is still no ovulation, one can move to the second line, which is gonadotropin, or we can add metformin, which is an insulin sensitizer to their first line medication, or laparoscopic ovarian diatemy could be done. And after this, if there's ovulation, then we wait for 6 cycle. And if still not pregnant, you can be encouraged to have in vitro fertilization. And if all this is done and there's still no pregnancy or no ovulation, then in vitro fertilization is recommended directly. It's good to know that there are long-term health consequences of polycystic ovary syndrome, and this includes cardiovascular disease risk. From the point of presentation, this risk assessment should be done in these patients, and also on follow-up, regular blood pressure monitoring, lipid profile monitoring is recommended in patients with polycystic ovary. Gestational diabetes, the risk is twice higher, and so screening should be done, especially in those preparing for pregnancy, or before 20 weeks in those who eventually get pregnant. All polycystic ovary syndrome women who get pregnant should be offered the test between 24 to 28 weeks gestation. Impaired glucose tolerance and type 2 diabetes mellitus. Polycystic ovary syndrome is an independent risk factor for type 2 diabetes in middle age, irrespective of whether they are obese or not. Obstructive sleep apnea is another problem in these patients. There are psychological issues and behavioral disorders that are linked with polycystic ovary, especially because of their builds. Endometrial cancer. Polycystic ovary syndrome has 2 to 6-fold increased risk of endometrial cancer, which often present before menopause. In polycystic ovary syndrome, interval between menstruation of more than 3 months may be associated with endometrial hyperplasia, which may further lead to endometrial cancer. Those with persistently thickened endometrium on transvaginal scan, especially when it is more than 7 mm, should be advised to have an endometrial biopsy and or hysteroscopy to rule out endometrial hyperplasia. Low threshold for investigation of endometrial cancer in polycystic ovary syndrome is required. It is good practice to recommend treatment with progestogens to induce a withdrawal bleed at least every 3 to 4 months in patients who are amenorrheic. Another approach includes combined oral contraceptives or progestin therapy in those with cycles that are longer than 90 days. Breast and ovarian cancer. There does not appear to be an association of polycystic ovary syndrome with risk of postmenopausal breast cancer and ovarian cancer. And so women with polycystic ovary syndrome do not require surveillance over and above that offered for the general population. In conclusion, polycystic ovary syndrome is an heterogeneous disorder and is of public health importance, with major impact on the quality of life of women that transcend beyond the reproductive age. So a prompt diagnosis, appropriate symptom-oriented management, and long-term follow-up will improve the outcome in women with polycystic ovary syndrome. Thank you.